Hi everyone. Let's move towards our next topic in obstetrics, which would be obstetrical complications. The complications include preterm labor, pre-labor rupture of membranes, which is also known as PROM, post-term pregnancy, intrauterine fetal demise, IUFD, intrauterine growth restrictions, IUGR, macrosomia, polyhydra or oligohydramnios, or antenatal depression. So that would be some complications, some obstetrical complications. Let's start with preterm labor. Right here. So preterm labor would be the labor induced preterm, and preterm would be before 37 weeks of gestational age and after 20 weeks. So 20 weeks is the cutoff. Anything before 20 weeks, we just count it towards abortion, right? So between 20 to 37 weeks, it would be preterm labor. What might be the causes of preterm labor? It could be maternal, fetal, or uterine. In maternal causes, the patient might have some infection going on, some chronic medical illnesses like hypertension, diabetes, and a preeclampsia, or maybe maternal age is advanced, some socio-environmental problems like poor nutrition, smoking, drugs, or some mechanical factors true like previous obstetrical or gynecological or abdominal surgeries. So that might be a mechanical factor which might induce labor earlier. And in maternal fetal causes, there would be PPROM, which is pre-labor. So it would be premature pre-labor rupture of membranes. So that would be rupture of membranes, right? So rupture of membranes would might lead to labor to polyhydramnios, placenta is attached at the wrong location, which is placenta previa, placental abruption, as we studied in our previous topic, that the placenta detached earlier, so placental abruption, placental insufficiency. So any of these might cause preterm labor. And then fetal multiple gestation, some congenital abnormalities, or fetal hydrops. Moving forward to uterine causes, just like we read in multiple gestation or mechanical factors. So multiple gestation would indicate towards excessive enlargement, and we read polyhydramnios and multiple gestation. So hydramnios and multiple gestation would induce enlargement, excessive enlargement in uterus, which might cause preterm labor. And then there might be some malformations in the uterus too, like leiomyomas or maybe septate uterus. So these are some causes that might cause preterm labor, and preterm labor is the most common cause of neonatal mortality. So it can cause neonatal mortality. Moving forward, risk factors. What might be the risk factors? So prior history of spontaneous preterm labor is the most important risk factor. Okay, so we have to keep this in our consideration that if there is any prior history of spontaneous preterm labor, we have to try to prevent the preterm labor in current pregnancy, and we'll read how we can prevent it. Here's the prevention of preterm labor, maybe by cervical cerclage, giving progesterone, or some lifestyle modifications. So if we know that this patient has a history of spontaneous preterm labor, then we need to monitor that patient closely, and we need to do some prevention of preterm labor earlier. Prior history of larger multiple cervical excisions like cone biopsy, or mechanical dilations like dilatation and curettage. So that might be a risk factor too. So preterm labor has a lot to do with cervix, so we have to make sure that if there has been any changes in the cervix earlier, then that might be a risk factor for preterm labor. If there might be any excisions, if there were any mechanical dilatation, or if there's a problem with the cervical length too, because you can see over here cervical length measured by the transvaginal ultrasound. So that is very important. Cervical length more than 30 millimeters, which is 3 centimeters, has a high negative predictive value for PTL before 34 weeks of gestational age. So before 34 weeks of gestational age, we can consider cervical length of more than 3 centimeters, which is good. Negative predictive value means there are very less chances that there would be any false negatives. Negative predictive value means there are higher chances of true negatives, like whatever would be negative, it would be true. So if it says cervical length is more than 3 centimeter, then like there are least chances for preterm labor, that it has higher negative predictive value. So cervical length less than 3 centimeter might be a risk factor towards preterm labor. I searched it up too. So, a cervical length of less than 3 centimeter measured between 10 to 24 weeks of gestation is associated with preterm births and favors vaginal birth, whereas cervical length more than 4 centimeters is associated with postnatal pregnancy. So, it should be within the normal range. But over here, we read if it is less than more than 30 millimeters, which is more than 3 centimeters, that it might be okay. Other than that, so we read previous history of PTL, preterm labor, any changes in the cervix. By that we mean any excisions from it. By that we mean any changes in the length of cervix. And then after that, we have to identify some infections like bacterial vaginosis or ureaplasma, uroloticum infections. So we have to routinely screen the high risk woman. Not routine screening, just screen the high risk woman. And then maybe any family history of preterm birth, smoking, late maternal age, multiple gestation, cocaine. So smoking, cocaine, alcohol, all of these might be a risk factor for any kind of complications. But in here, our main consideration is for prior history of spontaneous preterm labor and any changes in the cervix. And family history of preterm birth also matters, okay? So now, how are we going to prevent preterm labor? Now, if we see that our patient has some risk factors regarding preterm labor, how are we going to prevent? So there's a way which we call a cervical cerclage. What we do is place cervical sutures at the level of internal os, usually at the end of first trimester or in the second trimester, and they're removed in third trimester. So what we do is we put some cervical sutures at the level of internal os. And when we do it, whenever we find that this patient has cervical incompetence. How do we know that they have cervical incompetence? What does cervical incompetence mean? So it means cervical dilation and effacement. We didn't have the patient didn't have any uterine contractions, but the cervix dilated and effaced. It shortened and effaced and dilated. This is cervical incompetence. So this is the indication where we would like to put cervical cerclage, okay? And how do we diagnose cervical incontinence? Like, how would we know that this patient has cervical incontinence? So if there is any, if we take their obstetrical history during their previous babies, there was some silent cervical dilation. I mean, there's no contractions, but the cervix started to dilate. Or there were recurrent second trimester losses. Or they had some cervical procedures, just like we read in the beginning, any cone biopsy, any loop excisions, any cervical procedures. So these are the risk factors to which we could say that, okay, this patient might have cervical incompetence and this patient is eligible for cervical cerclage. And we can also check it by the ability of cervix to hold an inflated Foley catheter during a hysterosonogram. So we could just inflate a Foley catheter, insert and then inflate a Foley catheter, and just try to look at the ability of the cervix to hold it. Transvaginal ultrasound of cervical length is recommended only for the high-risk pregnancies and only before 28 weeks. So we can also do transvaginal ultrasound. So these are the three ways how we can diagnose the cervical incompetence. If in history there were some problems in the second trimester, there were some cervical procedures, and if we can also check by the Foley catheter, and we can also do transvaginal ultrasound to measure the cervical length, and that should be done before 28 weeks because we are trying to prevent preterm labor, so that should be done as early as possible. Proven benefit and prevention of preterm labor in women with primary structural abnormality of the cervix. So if they had any structural abnormalities, if they had any conization of the cervix, any connective tissue disorders, problems with the cervix, cervical cerclage can help it. It's like suturing the end, right? It just holds the baby up for the maximum time when it was vulnerable. We read that second trimester losses, if they had recurrent, then we have to get it done in second trimester or at the end of first trimester. So just the vulnerable time during that time, in which there might be a possibility of cervical incompetence and preterm labor again, we could just put on the sutures and we can remove them in third trimester. Let me show you that right here. So that's how a dilated cervical canal looks like, and after the sutures it's narrowed. It just holds the baby in. so that preterm labor doesn't happen. And then it's given to the is a way of keeping your cervix closed during pregnancy to prevent premature birth due to the incompetent or weakened cervix. Okay. Um, other than that, other than the cervical cerclage, what if there's no cervical incompetence? What can we do then? We have some ways like lifestyle modifications or progesterone also. We don't know exact mechanism for that, but the progesterone just helps control the uterine contractions. So if the cervical length is less than 25 millimeters at less than 24 weeks of gestational age, so it's pretty early, it's like early second trimester. So 24 14, okay, so it's like, no, it's not early, but it's second trimester. So if cervical length is less than 25 millimeters, which is 2.5 centimeters, we said less than 3 centimeters would be bad. So if it is less than 25 millimeters and we are checking it at around 24 weeks of gestation, then we have to give progesterone. So if they have short cervix, what we can do is, now short cervix wouldn't be good if we do cervical cerclage in it, because it's not about holding, it is just short. So what we can do is we can give 200 milligrams vaginally once daily from time of diagnosis to 36 weeks of gestational age. So till 36 weeks we can keep on giving them progesterone as soon as we diagnose it, and we have to, as we are preventing, we have to check it earlier. So we do transvaginal ultrasound, we see if the cervical length is less than 25 millimeters, we start 200 milligrams of progesterone vaginally till 36 weeks. And if risk factors of history of preterm labor present, give vaginally starting. We can also start them even earlier if there are any other very high risk factors like previous history of preterm labor. And progesterone is superior to cerclage in preventing preterm labor of singletons not due to cervical incompetence. So if there's cervical incompetence is not a problem, then we'll go for progesterone as it is superior to cerclage. Moving forward, lifestyle modification, smoking cessation, substance use reduction, treatment of any GU infections, and patient education regarding the risk factors. Predicting preterm labor. How can we predict preterm labor? We had a little table right here too, talking about positive fetal fibronectin in the cervicovaginal fluid. So it is the same thing. How do we predict preterm labor? What is fetal fibronectin? It is a glycoprotein which is present in the amniotic fluid and it is present in the placental tissue. But if we check the vaginal fluid, some cervicovaginal fluid, and it is positive for fetal fibronectin, if it has more than 50 nanograms per milliliter, then it might be an indication towards preterm labor. Why would you do it? Like, you wouldn't do that for every patient, right? When would you do it? So if you see any signs of preterm labor, if you see any signs of regular contractions more than 6 per hour, any pelvic pressure, lower abdominal pain, cramps, lower back pain, and if these are present, we read that preterm labor is 20 to 37 weeks, right? 20 to 37 weeks of gestational age. So if it happens between 24 to 34 weeks of gestational age, then we can go for this test, and we do it done only if there are some indications 24 to 34 weeks of gestational age, intact membranes, less than 3 centimeter dilated, established fetal well-being. Then we'll go for this test. Because if membranes are not intact, then what's the purpose of doing this test? We already know that there's a rupture of membranes, right? So if the membranes are intact, cervix is not dilated, and they have some contractions, and you know the baby is okay. First priority is to make sure that fetal well-being. You know that well-being fetus is okay, and patient is having some regular contractions, some abdominal pain, lower backache. Then we can go for this fetal fibronectin test. And when is it contraindicated? If they have active vaginal bleeding, if any vaginal exam happened, or sexual intercourse in the last 24 hours. So then there's no use of doing predicting preterm labor by fetal fibronectin. If negative, not likely to deliver in 7 to 14 days, and this is accurate. So if there is no fetal fibronectin in the cervicovaginal fluid, you don't have to deliver them in the next 2 weeks. But if it is positive, that means that there would be an increased risk of delivery. That means that there is preterm labor has started, and now you might have to deliver the baby. So you might need to transfer the baby to the patient to a center where delivery could be possible. Okay, so you have to get the patient prepared. You can also start some tocolysis so that you can get at least some minimum amount of time in which you can also administer corticosteroids, so that the majority can happen, and you just can administer corticosteroids. So that's why we do tocolysis. You try to suppress labor. You don't really try to suppress it completely and it's just gone. No, it doesn't happen like that, but you just suppress it so that you get enough time to administer corticosteroids. So what are the clinical features of preterm labor? Regular contractions, more than 6 per hour. In 10 minutes, they're having 2 contractions. Cervix is more than 1 centimeter dilated and more than 80% effaced, or length is less than 2.5 centimeters. So any of these, the cervical length is decreased, less than 2.5 centimeter, more than 80% effaced, and cervix has started to dilate it, more than 1 centimeter dilated, then we could say, and there are regular contractions, it is labor. Okay, and how would you manage? So initial, it's just monitoring and making sure that we can transfer the patient as soon as possible. Then tocolysis, we have to try suppressing the labor so that we can start with some corticosteroids and make sure that the patient is transferred safely, and then some neuroprotection. So initial transfer, tocolysis, and first dose of antenatal steroids. Prior to transfer, make sure it's done during the way. Make sure they are properly hydrated. Bed rest and left lateral decubitus position. Why? So that the aorta and the vena cava, those are compressed by the big uterus. The uterus has occupied some space, so to reduce that compression and so that the cardiac output is improved, there is better circulation. It is best that the the patient should lie on their left lateral decubitus position. And analgesia for the pain when they're having contractions. Avoid repeated pelvic exams so that you avoid any infections. Ultrasound examination of fetus. Try keep on monitoring the fetus too, the biophysical profile, and so that you can pick up any fetal compromise as early as possible. Prophylactic antibiotics for GBS. Important to consider if there was rupture of membranes also. So you have to make sure that if there is rupture of membranes, first thing you go for is antibiotics, because you don't want to get any infection, get them infected. So tocolysis, suppression of labor, it does not inhibit the preterm labor completely, but it may delay the delivery. So why would you want to delay the delivery? One, to allow for the antenatal steroids like betamethasone, Velrate, or dexamethasone, and then to transfer them to appropriate center for care of the premature infant. What is the requirement for tocolysis? So requirement is there is preterm labor, baby fetus is live, immature fetus, membranes are intact. If membranes are still intact, then you want to give tocolysis. If the membranes are ruptured, there's no use of tocolysis. And cervical dilation is less than 4 centimeters. So you don't want your first cervix to be 8 centimeters, say 6 centimeters, and you're giving tocolysis. That's like making it more complicated. Absence of maternal or fetal contraindications. So if there are no contraindications, there is no fetal or maternal compromise, membranes are intact, cervix is not dilated more than 4 centimeter, it is less than 4 centimeter, and there is preterm labor, then you go for tocolysis. And when is it contraindicated? If you see any bleeding going on, placenta previa or rupture, there is any maternal disease, chorioamnionitis, any infection going on, any fetal problems, fetal distress, IUGR, congenital anomaly, so any of such problems, then it is contraindicated. Then you'll make sure that you don't suppress the labor and you don't complicate it even more. How do you tocolyze? How do you do the tocolysis? How do you suppress it? Calcium channel blockers like nifedipine, or prostaglandin synthesis inhibitors like indomethacin. Calcium channel blockers, nifedipine has some relative contraindications if the patient has allergy or hypotensive or any liver problems, or they're using magnesium sulfate concurrently, because we do use magnesium sulfate for neuroprotection in preterm labor. So make sure that if they're using concurrently, then you shouldn't be using nifedipine. And their absolute contraindications is make sure the mother herself doesn't have any chronic congestive heart failure or aortic stenosis. You wouldn't want to give that calcium channel blocker. You wouldn't want to create hypotension. So then, in those cases, the first line for early preterm labor would be indomethacin. So you're gonna go for indomethacin. There are some contraindications for that too, which is peptic ulcer disease or any renal or hepatic impairment. Then we're going to go for corticosteroids, betamethasone, Valrate, or dexamethasone, given between 24 to 34 weeks, if expected to deliver in the next 7 days. But if it is earlier than that, what we do is we provide them multidisciplinary consultation. We tell them that there would be severe perinatal morbidity, mortality. Consider antenatal corticosteroid therapy if they're planning for early intensive care. So then you can consider administrating that. Otherwise, it's just more of a consultation thing, because you have to get the parents prepared for the chances of severe perinatal morbidity and mortality. But between 24 to 34 weeks, make sure that is 35 weeks, right? So 24 to 35 weeks, make sure you're giving the antenatal corticosteroids. What does it do? It enhances fetal lung maturity, reduces chances of perinatal death, and reduces the incidence of severe respiratory distress syndrome, intraventricular hemorrhage, necrotizing enterocolitis, or neonatal sepsis. So it reduces the incidences of these severe problems, and it also enhances fetal lung maturity. So make sure between 24 to 36 weeks, 35 weeks, you are administering antenatal corticosteroids. There's specific maternal contraindication. If she has active TB, then you're not going to do that. For neuroprotection, we are going to give magnesium sulfate, 4 grams bolus, followed by 1 gram per hour infusion. For at least 4 hours if imminent delivery expected, and it is less than 34 weeks. So if it is less than 34 weeks, then you're going to go for magnesium sulfate. What is the prognosis? Prematurity is the leading cause of perinatal morbidity and mortality. Premature babies. But if the babies are 24 weeks, at 24 weeks gestational age, 50% survival. 30 weeks gestational age, 90% survival. 33 weeks gestational age, 99% survival. So what does the morbidity depend on? It depends on hypoxia, asphyxia, sepsis, RDS, IVH, thermal instability, any of the fetal complications, any of the fetal compromise. Morbidity directly depends upon it, of course. And prematurity, what does prematurity do? Because of the preterm labor, we delivered the baby and the baby is premature now. So it increases the newborn risk of respiratory distress, hypoglycemia, hyperbilirubinemia, apnea, feeding difficulties, seizures. So that's the next step. The obstetrical complication was preterm labor induced. Because of the induced labor, there was delivery, and baby was premature, and now this whole series would start. So we have to be taking care of them in intensive care. Moving forward, pre-labor rupture of membranes, which is PROM. If it is the rupture of membrane happened and the onset of labor, the time elapsed between the rupture of membrane and onset of labor would be more than 18 hours. We'll call it as prolonged rupture of membrane. And if the rupture of membrane, which was pre-labor, right? Labor didn't start, membranes got ruptured. If it was pre-labor rupture of membranes and it was preterm too, it was before 37 weeks, right here, before 37 weeks, then that would be preterm and PROM. So PPROM, preterm and pre-labor rupture of membranes. It has some risk factors too, like maternal multiparity, cervical incompetence, infection going on, any low socioeconomic class, or for because of that poor nutrition, rupture of membranes happen. Infection is pretty common. And in fetal, it could be because of multiple gestation or any congenital anomalies. Other risk factors are associated with preterm labor. Okay. What would be the clinical features? How would you know it's prom? There would be the patient would give you a history of fluid gush or continued leakage. How would you investigate it? Make sure it is sterile. You wouldn't want to give them infections. So sterile speculum examinations, and make sure you do not do examinations too often. Sterile speculum examination, what would you see? Pooling of fluid in the posterior fornix, and there would be cascading. What is cascading? You'll ask your patient to cough or do the Valsalva maneuver, and there would be fluid leaking out of the cervix. So that means the membranes have ruptured. Nitrazine, what is nitrazine? What does it do? So the amniotic fluid is basic, and if we do the nitrazine test, the nitrogen paper turns blue because there is amniotic fluid. Furning's test. Salt in the amniotic fluid evaporates, and there's an appearance of ferns on microscopy. I searched it up, and it said that the salts, because of the higher levels of estrogen present in there, which is in during the pregnancy too, the cervical mucus forms fern-like patterns due to crystallization of sodium chloride on mucus fibers. So we could just have a quick look. Right here on light microscopy, you would see some ferns in the amniotic fluid. So salt in the amniotic fluids would be seen. So ferning is a test of one of the investigations, and we can also do ultrasound to rule out fetal anomalies. You can assess any the estimated fetal weight, presentations, and biophysical profile. Membrane status is determined by pooling of fluid on speculum exam, increased pH of vaginal fluid, which is nitrazine test, which turns blue because of the increased pH or basic pH of amniotic fluid, ferning of fluid under the light microscopy, and decreased amniotic fluid volume on ultrasound, of course, because it leaked, so the volume would be decreased. How would you manage? There's rupture of membrane, right? So expectant management. Monitor the vitals every 4 hours. Daily do the non-stress test on baby WBC count, and you just have to make sure that you are preventing any sort of infections. And that's how do you do it? You minimize the vaginal examinations. And if there is a rupture of membranes, you would want to give the baby administer steroids. So betamethasone administration if less than 35 weeks. So this is what you have to learn, less than 35 weeks. Right here we read 24 to 35 weeks. So less than 35 weeks, make sure you give them antenatal steroids. Consider tocolysis for 48 hours to permit administration of steroids if P-PROM induces labor. So if there was pre-labor rupture of membranes, but if it was preterm, then, and if the rupture induces labor, then you would want to give tocolysis so that you'll be able to give steroids. You have to screen the patients for any sort of infections. Consider antibiotics. Penicillins are antibiotics of choice, and if you have to deliver urgently. If there's any fetal distress or any fetal or maternal compromise, go for delivery, because rupture of membranes have already ruptured. Even there's the labor didn't start, you would have to go. If there's any compromise, any chorioamnionitis, you would have to deliver. Here's a table how to manage the pre-labor rupture of membranes. If it is 22 to 25 weeks, then counseling of parents, letting them know that how would this affect their baby, and if we deliver them, how would that affect it, how their baby would be premature, and what are the risk factors for it. And then 26 to 34 weeks, you're gonna do the expectant management, as prematurity complications are significant, because that would be a very premature baby before 34 weeks, right? And expectant management would definitely include corticosteroids. And after 34 to 36 weeks, now this is the gray zone, where risk of death from respiratory distress syndrome, even if you delivered the baby, they would have respiratory distress syndrome and neonatal sepsis, and even if you don't, they would have fetal compromise. So this is a gray zone, 34, 35, 36 weeks. And more than 37 weeks, you'll just induce labor, and because over here risk of death from sepsis is greater than RDS, so you would want to make sure that you don't want them to die because of sepsis. Even if there is RDS, they'll be able to get steroids and resolve, that would be able to resolve, but you would want to induce labor if it is more than 37 weeks. Prognosis varies with gestational age. There are some complications: cord prolapse, intrauterine infections, premature delivery. Of course, it's rupture of membrane, so that might cause some infection. Would be the first thing coming to your mind, and then ruptured, so premature delivery, any limb contraction, any pulmonary hypoplasia, because it was preterm, right? It was early, very early gestational age, and cord prolapse. Okay, moving forward, post-term pregnancy. After 42 weeks, it would be post-term. So 37 to 42 would be term, but after 42 would be post-term. That is why labor induction is recommended at 41 plus 3 weeks of gestational age. So don't let it go past 42. If it's past 41, 3 days, labor induction is recommended. So pregnancy which is after 42 weeks is called as post-term. Why would it happen? There would be some unfortunate fetus in which there would be anencephaly, and there would be no pituitary gland to induce it. So anencephalic fetus with no pituitary gland, there might be some deficiency of placental sulfatase. It is an X-linked recessive condition, or there would be problem with dates. It is incorrect. They have incorrect dates. So it might not be post-term, it might be a term baby. So that could also be a reason. So major two reasons are anencephalic fetus and placental sulfatase deficiency. And what's the prognosis? If more than 42 weeks of gestational age, perinatal mortality increases 2 to 3 times. And with increasing gestational age, there would be high risk of many things. So it could be infection, asphyxia, meconium aspiration, placental insufficiency. Placenta might be aging and having infarction, macrosomia, dystocia, fetal distress, any operative deliveries, and then complications because of that: pneumonia, seizures, NICU admission, stillbirth. So morbidity increases with gestational hypertension, diabetes, abruption, IUGR, advanced reproductive age, and multiple gestations. So prognosis is not good. If it is after 42 weeks, perinatal mortality is 2 to 3 times higher because it's after 42 weeks. So there would be progressive uteroplacental insufficiency. Moving forward, this was post-term pregnancy, which is after 42 weeks. Then we have intrauterine fetal demise. It would be if the fetal demise occurs in utero after 20 weeks of gestational age. If it is before abortion, so 20 weeks is the cutoff point. So if it is after 20 weeks, we call it as intrauterine fetal demise. It occurs in high-risk pregnancies. Etiology is idiopathic. It could be because of maternal causes, maternal illnesses, hypertension, diabetes, any infection going on, antiphospholipid syndrome, and it could be because of the maternal fetal complications, any congenital anomalies, fetal complication. It could be just because of maternal fetal would include erythroblastosis fetalis, and then it could be just the fetal side, umbilical cord complications, or any congenital anomalies. How would you know there's intrauterine fetal demise? Decreased perception of fetal movements by mother. They would inform you that they don't feel any movements anymore. So in history, the basic thing which we do ask them is ABCDE. Activity, any bleeding you saw, do you feel any contractions now, and it was any discharge, and what was the estimated date of delivery. You recalculated every visit, right? So if they don't feel the activity, that's a red flag. So if they say that there's decreased perception of fetal movements, and then when you measure the symphysiofundal height, then it is lagging behind. And if the maternal weight is not increasing as it should be, and then we do the Doppler, we don't hear the fetal heart tones. And then if we do the testing, blood testing, maternal serum maternal serum alpha fetoprotein is high. That would be an indication towards intrauterine fetal demise. On ultrasound, no fetal heart rate. So these are some investigations you would do. But coming from the mother, it would be decreased perception of, they wouldn't be feeling any activity. Depending on the time of death, you may see skull collapse, you may see the brain tissue retraction, empty fetal bladder, non-filled aorta, because it depends on the time of death. If it was pretty early, the aorta wouldn't be filled by now. Okay, it's just empty by now. And poor visualization of midline falx, which is the my mind just skipped that word, the folding of the dura mater between those cerebrum, right? So that falx, it's in the brain, right? So midline falx, the poor visualization of it, so there's the development stopped, brain tissue retracted, skull collapsed. So depending on the timing of death, you could see any of these things in intrauterine fetal demise. How would you manage? How would you diagnose? Absent cardiac activity and no fetal movements, we do ultrasound. On ultrasound, no fetal cardiac activity, no fetal heart rate, no fetal movements. You would just want to determine the secondary cause, what was behind it. So in maternal, you'll do some investigations. You would want to rule out diabetes, thyroid, any cross reactivity, any infections like syphilis, SLE, any anti-phospholipid syndrome. You would also want to do some coagulation studies of the patient, of the mom, and then urine toxicology screens for any intoxication, any cultures for any infections, and heart screen. So you would gonna go for HbA1c, glucose, TSH, Clee-Harbutt test, VDRL, ANA, CBC, anticardiolipins, antibody secretions, INR, PTT, urine toxicology screens, cervical, vaginal cultures, and heart screens. And in fetus, you would want to determine the secondary cause, like what was behind it, what caused the fetal demise. So you're going to go for karyotype, cord blood, skin biopsy, genetics evaluation, autopsy, amniotic fluid culture for maybe cytomegalovirus, parvovirus B19, and herpes. And for the placenta, you're going to send it for pathology and bacterial cultures. I don't think there should be a word like treatment. How would you manage it? If it's past 20 weeks, of course, it's not abortion, it's fetal demise. So it would be just induction of labor with vaginal misoprostol. You would just induce labor, and you would just take it out of the mommy's body, and then you would monitor maternal coagulopathy, because there might be a risk of DIC. Just like placental abruptio, in placental abruptio we read that there might be a risk of DIC. So over here too, when you're gonna give misoprostol, and you're gonna wait for the baby to be removed, you would make sure that you prevent DIC. All right. So because there is 10% risk of DIC, so you would just want to make sure that you monitor maternal coagulopathy. Obstetrical causes for DIC. And why does DIC happen? Because there would be generalized coagulation. Because of losing the baby, there would be coagulation. And because of the generalized coagulation, there would be the coagulative factors would be depleted, and where they are needed, they will not be present there. So there would be rashes and whatnot. So DIC might be caused by abruption, gestational hypertension, fetal demise, and postpartum hemorrhage. So you want to make sure you know these causes. It is an important topic in obstetrics, DIC. And how do you investigate? CBC, APTT, PT, prothrombin time, FDP, fibrinogens, and treat the underlying cause, supportive fluids, make sure blood products are ready, fresh frozen plasma, platelets, cryoprecipitate, and consider anticoagulation as the venous thromboembolism prophylaxis. So you might consider anticoagulation in DIC. In fetal demise, one of the life-threatening complication would be DIC, and it is 10% of risk. So make sure you're gonna monitor. You're gonna remember if there are any CDMs that okay, there was fetal demise. It was after 20 weeks, and it was unfortunate, and there was fetal demise, and make any scenario out of it, and what are your next steps to do, how would you manage it. So that's what we want to do, that induction of labor and getting it out by vaginal misoprostol. But what next? So you want to make sure that mom is mom is safe. So you're going to make sure that you're monitoring maternal coagulopathy to reduce the risk of DIC. And what next? It's not just that. It doesn't end over there. There should be bereavement support as per hospital protocol and psychological care. And then after that, right there and then, you cannot discuss this, but there should be a comprehensive discussion within 3 months. Make sure you remember that within 3 months, there should be a comprehensive discussion about final investigation and post-mortem results. Help make plans for future pregnancies. So you're going to make sure that you inform them about the reason. What was the reason behind it? As you sent over so many investigations, you send over autopsy, you send over amniotic fluid cultures and whatnot, baby's cord blood, and then karyotype. So you need to make sure that in the CDM you also write this thing, that within 3 months there should be a comprehensive discussion about the final investigation and post-mortem results. And if any of the causes identified, then what to do for the future pregnancies to prevent it not to happen again. So you have to plan for the future pregnancies to help them to make plans. Moving forward, intrauterine growth restrictions. Intrauterine growth restriction is the failure of a fetus to reach its biologically determined growth potential. So its growth is restricted. 50% of the causes are unknown, but we can think of the risk factors. It could be the maternal, placental, or fetal. Maternal, of course, malnutrition. You're not giving the baby nutrition enough so that they can grow. They would be lagging behind. So failure of fetus to grow up to their mark, up to their potential. Smoking, alcohol, stress, drugs. That's the lifestyle. That's the modifiable factors. If they're there, it might cause growth restriction. Then maternal illnesses like heart disease, diabetes, SLE, pulmonary insufficiency. Previous IUGR, 25% risk. So if there was previous growth restriction, previous babies were restricted in their growth, then there might be a risk of 25% risk of happening it again. Chronic hypertension, gestational hypertension, so any kind of chronic illnesses. Prolonged gestation also indicates intrauterine growth restriction, because then there would be progressive placental insufficiency. Placental problems like placental insufficiencies, any infarction, hemangioma, placenta previa, abnormal cord insertion. So the nutrition is good, but the interface from where they're going to get the nutrition, the baby's going to get their nutrition, there's some insufficiency going on. Or in fetus, there is TORCH infections, toxoplasmosis, others syphilis, rubella, CMV, HSV. So there's some TORCH infection going on, which is not letting the baby to grow up to their full. Multiple gestation, congenital anomalies, or chromosomal abnormalities. What are the clinical features of growth restriction? It could be either symmetrical or asymmetrical. If it is pretty early in pregnancy, then it would be symmetrical, right? So if the growth restriction started pretty early, then it would be symmetrical. That is, the head and the body would be symmetrically restricted in growth. If the abdomen circumference is reduced, head circumference would also be reduced. So the ratio may be normal. And what is the normal ratio? Right here, before up to 32 weeks it should be more than 1, but after 34 weeks, which is like baby is growing, it should be less than 1. So head is a little bit comparatively a little smaller than the body. It is less than 1. Ratio is less than 1. So that's how it would be normal, right? And if the ratio is normal in symmetrical growth restriction, and it is usually associated with any congenital anomalies or horse infections, so any infections or any congenital problems, and that happens early in the pregnancy. But if it happens pretty late, which is the case, which is the most common case, up to 70% is asymmetric. So if it happens late in pregnancy, what happens is fetal abdomen is disproportionately smaller right here, and fetal head is paired. No problems with the head. So head circumference by abdominal circumference would be increased. Why does this happen? It happens later in pregnancy. It happens because of placental insufficiency. Because of insufficiency, there might be any cause. It might lead towards less nutrition towards the baby, less blood to the baby, so growth is restricted. But asymmetric, as it is more common, it has more favorable prognosis too. Why do you think so? Because in symmetric, head is also being affected, brain development is also being reduced, but over here, um, fetal abdomen is disproportionately smaller than the fetal brain is paired right here. Brain is paired, so it has better favorable prognosis in asymmetric. And fortunately this one is common, so we can make sure that it is resolved. Complications would lead to meconium aspiration, asphyxia, polycythemia. Because of growth restriction, all of these would be decreased too. Less glucose, less calcium, less phosphate, hyponatremia, intellectual disability, and greater risk of morbidity and mortality too. How would you investigate symphysiofundal height measurements at every antepartum visit, which you already do? So if they're lagging behind more than 2 centimeters, then the mother is at high risk. So symphysiofundal height is in non-invasive. It should be done at every antepartum visit. After that, if they are lagging behind the gestational age, so I believe after 20 weeks of gestational age, it should be on 20 weeks it should be on the umbilical cord, and after that 2 centimeters, around 2 centimeters, respective to the gestational age. Let me quickly look. There was a side table. Right here. So at 20 weeks, it is at the fundus of uterus is at umbilicus, and from 22 onwards, the symphysiofundal height should be within 2 centimeters of gestational age, right? So if it's 22, so it should be within 2 centimeters, so it could be within 24 or 20, within this range. The height could be within this range. I mean, not 22 to 24. This is not the measurement. It should be, if this is umbilicus, then it should be 2 centimeters above or below. So within 2 centimeters of gestational age. Yes. Okay. Right. So if we measure the symphysiofundal height, then we can go for further investigations. We're going to go for ultrasound, for biparietal diameter, for head circumference to abdominal circumference ratio, for fetal length, fetal height, amniotic fluid volume, because it would be decreased if there's growth restriction and decrease in the rate growth. We can also do the biophysical profile, Doppler analysis of umbilical cord blood flow, that if they're having enough blood flow or not. What we can do, first of all, we should be preventing it by the risk modification prior to pregnancy, by controlling the modifiable risk factors like smoking, drugs, alcohol. So first of all, trying to prevent it that way. Then we can also closely monitor it. Serial biophysical profile, monitor fetal growth, determine cause of IUGR if possible. And if we are going to go for delivery, when we're going to go for delivery, if the extrauterine existence is less dangerous than continuing the pregnancy, if there's absent growth inside, if there's severe oligohydramnios, then we're going to prefer delivery over it, especially after 34 weeks. So how are we going to do that before delivering? Of course, we're going to make sure we're giving antenatal corticosteroids, magnesium sulfate for neuroprotection. And if there's usually the swab is done 35 to 37 weeks of gestational age, the GBS swab. But if now we are delivering the baby earlier, so make sure that you're giving and doing that swab, and if there is positive, then you're giving intrapartum antibiotics and pediatric consult, because if there is preterm delivery, so you would have to keep the baby in intensive care. As IUGR fetuses are less likely to withstand the stresses of labor, they are more likely to be delivered by cesarean delivery. So make sure that you keep this in your mind too. So growth restriction, this was all. Then macrosomia. What is macrosomia? As its name indicates, the infant's weight could be more equal to 90th percentile or more than 90th percentile for a particular gestational age. It could be more than 4,000 grams, which is 4 kilograms. What are the risk factors? Of course, diabetes, maternal obesity, past history of macrosomic infants, prolonged gestation, multiparity, excessive maternal weight gain during the pregnancy. And how would you know what would be the clinical features of macrosomia? There would be during the delivery, there would be cephalopelvic disproportionates. There would be birth injuries because the baby's size is huge. So shoulder dystocia, fetal bone fractures are common, and then complications of diabetes in labor too. Because we have read the diabetes or any chronic medical illnesses in labor might be causing complications like, just like we read right here, growth restriction, type 1 diabetes, and then the maternal side complications, diabetes mellitus, fetal demise. Not the postpartum pregnancy, I believe, but it might be a cause too, because the babies are usually bigger. And then right here, rupture of membrane is usually because of infections. And then preterm labor, diabetes. So all of these complications in macrosomic baby, the complications of diabetes, they can be happening in labor too. And okay, so it was this line meant in labor specifically. I was talking about obstetrical complications in labor. What would happen that because of the baby size, there might be prolonged stages of labor. Second stage of labor, there might be prolonged labor, and then maybe there might be some arrest and in labor. So that's the other thing. We're gonna read it when we're gonna do read about the labor. And how would you investigate macrosomia? You would just do serial symphysiofundal heights, you do ultrasound, and if the symphysiofundal height is more than 2 centimeter ahead of gestational age, of course they are at high risk of macrosomia. How would you manage? You'll try to prevent hyperglycemia in patients with diabetes mellitus, and you'll try to optimize the pre-pregnancy weight and limit any excessive weight gain during the pregnancy. And it also depends on BMI too. So if the patients have high BMI, then we're going to try to limit the weight gain during pregnancy and prevent the hyperglycemia if the patient is diabetic, if mommy is diabetic. Planned cesarean delivery is a reasonable option where estimated fetal weight is more than 5 kilograms in non-diabetic, and even if the patient is diabetic, then even if more than 4.5 kilograms, 4,500 grams is the estimated fetal weight, we're going to go for planned cesarean delivery, because labor can have diabetes can have many complications in labor. And then shoulder dystocia and fetal bone fractures during the birth might be because of the cephalopelvic disproportion. These things might increase the risk of perinatal mortality. So we're going to prefer planned cesarean delivery. Moving forward, we have polyhydramnios and oligohydramnios. Poly means it has more. So the amniotic fluid index is more than 25 centimeter. In oligo it's less than 5 centimeters. So by definition, in ultrasound, the single deepest pocket of the amniotic fluid would be more than 8 centimeters, and it would be less than 2 centimeters in oligohydramnios. What might be the causes? Polyhydramnios, maternal size, diabetes, especially type 1. So make sure you know that type 1 diabetes would lead to polyhydramnios, multiple gestation, fetal hydrops, fetal side problems, chromosomal anomaly. This is an important thing. Chromosomal anomaly, up to 2 by 3 of fetuses have severe polyhydramnios. So if we have if by the maternal serum screening we get that the baby has some chromosomal anomaly, we should be expecting polyhydramnios with that too, because 2/3 of fetuses do have it. And then malformed lung, anencephaly, hydrocephalus. So any problems with the swallowing, so anencephaly, of course, the prognosis is pretty low, but situations like tracheoesophageal fistula or duodenal atresia, facial clefts, swallowing is being interfered, then the fluid would be just around there, and it would be just keep on increasing. So polyhydramnios. And in oligohydramnios, urinary tract problems, and demise or chronic hypoxemia, blood shunt away from kidneys to perfuse brain. So blood is redirected towards brain, and kidneys not being able to perform well. And intrauterine growth restrictions, or maybe rupture of membranes, which would be keep on the amniotic fluid would be keep on leaking, and it gets decreased. Amniotic fluid normally decreases after 35 weeks of gestational age. So this you should keep in mind. Around 35 weeks of gestational age, after it just normally decreases too. Okay. And clinical features, how would you know there's polyhydramnios? Of course, the uterus would be large for gestational age, and because of so much fluid, fetal parts would be difficult to palpate, and you would be unable to hear fetal heart rate. And the oligohydramnios, uterus would be too small. What could be maternal complications? Because of the big uterus, distended uterus, there could be pressure symptoms. And in obstetrical complications, cord prolapse, placenta would be abrupt, placenta would detach earlier, placental abruption, malpresentation, preterm labor, postpartum hemorrhage. Obstetrical complications in oligo, because there's less fluid, cord compression, adverse fetal outcomes, pulmonary hypoplasia. How would we manage it? Of course, determine the underlying cause, fetal ultrasound evaluation. If it is mild, require no treatment, but if it is severe, you might hospitalize the patient, and you might need therapeutic amniocentesis. So you might need to drain some of the fluid out. And just opposite to that, in oligohydramnios, you might consider amnio infusion. You might consider injection of fluid via amniocentesis, so that it could improve the condition for around a week, and it may be helpful for visualizing any associated fetal anomalies too. Because over here, I guess I missed this part, the fetal complications. Oligohydramnios has 15 to 25% chance of complications like fetal anomalies, right? So fetal anomalies can cause, any chromosomal fetal anomaly can be etiology for polyhydramnios, but if there is less fluid, that could lead to complications, which is fetal anomalies. And then there's amniotic fluid bands too. What is amniotic fluid band? Let me show you. What happens is, due to some unknown etiology, such bands form around their limbs, around their face, and the band wraps around their arms or fingers, and it causes swelling and blockage. So there might be some limb deformities like this, and Porter facies too. So Porter's facies, limb deformities, abdominal wall defects. So that would be happening in oligohydramnios, where the fluid is less. So whenever the fluid is less, it always warrants admission and investigation. You have to investigate. Rule out rupture of membranes. First of all, you just have to rule out rupture of membranes. That is like normal, right? Physiological. So not the rupture of membranes, but if there is rupture of membranes, of course, there's leakage of fluid, and there would be oligo. Fetal monitoring, making sure the fetal well-being, and ultrasound Doppler studies, umbilical cord and uterine artery. So after that, first of all, we just ruled out all the red flags, and then we'll make sure maternal hydration, oral or IV fluids. We can also do injections of fluid via amniocentesis. We can also, which is called as amnioinfusion, we can also consider delivery if it is term. So in oligohydramnios, always warrants admission and investigation. In polyhydramnios, mild to moderate cases require no treatment, but in oligo, you have to be more careful. And in poly, the prognosis 2 to 5 fold increase in risk of perinatal mortality, but in oligo, poorer with early onset, high mortality related to congenital malformations. So it causes malformations. The complications are higher in oligo. In poly, the complications are not that bad and not that specific, but poly occurs because of the poor prognosis already. Because if there's already an encephaly or hydrocephalus or meningocele, then what can we expect next? Okay. Moving forward, antenatal depression is our last topic in obstetrical complications. It is just like major depression. It could be onset, it could be started before pregnancy too. It is just like the major depressive disorder in non-pregnant patients. What are the risk factors? Depression, anxiety, if the pregnancy is unwanted, if there is intimate partner violence, and there might be some the medical cause too, like hypothyroidism, so we have to rule that out too. Some organic cause. Clinical features comparable to the symptoms of non-pregnant MDD. Suspect if prior history of depression, excessive anxiety, and some excessive anxiety about the fetus too. If there's poor self-esteem, if there's anhedonia, which is loss of interest, if they're not taking care of themselves or the baby, or there's poor weight gain because of appetite or suicidal ideation. So symptoms are probably comparable to the major depressive disorder, so we could talk about that. So it is MI, PAS, ECG, mood, interest, psychomotor retardation. They're very slow in their activities. Appetite, sleep, suicidal ideation, energy, low concentration, and G was guilt, low guilt. So these are the things which happen in a non-pregnant major depressive disorder. And MI are the most important ones, mood and interest. So if they're feeling low mood, they're feeling loss of interest, there's poor weight gain, they're not taking care, there's decreased appetite, they have excessive anxiety, there was prior history too, you're gonna suspect antenatal depression. You're going to assess them by Edinburgh Postnatal Depression Scale and then treat them with antidepressant psychotherapy or supportive care. If it is refractory, if there are signs of psychosis, catatonia, suicide, or fluid or food refusal, okay, and because of low appetite, fluid or food refusal, which would be very life threatening because they have a baby in them now and the baby needs food too, so that would lead to dehydration and malnutrition. So if any such cases, then we'll also go towards electroconvulsive therapy. What is catatonia? It is just bizarre behavior. I'll show you a very nice diagram. Yeah, this picture. So there is rigidity or stupor that lasts for hours or even days. They're performing strange movements, staying in uncomfortable positions without shifting, erratic and extreme movement, echolalia, which is repeating others' words or repeating others' behaviors and being very irritated. So if such situation occurs, psychosis occurs, they have suicidal ideations, we are going to go for electroconvulsive therapy. Other than that, we're going to go for antidepressant, psychotherapy, supportive care. And how is the prognosis? Increased risk of recurrence after pregnancy too. So if it is happening during antenatal, there is increased risk of recurrence, and there's increased risk of conversion of that diagnosis to bipolar disorder. It's not just gonna stay till pregnancy, it can be converted to bipolar disorder too. Alright, that's it for obstetrical complications. I hope it helped. Thank you.